Welcome to the recorded version of the Grantmakers in Aging web seminar, The Reauthorization of the Older Americans Act and the Federal Budget for Aging Programs. Why Philanthropy Should Care, featuring Kathy Greenlee, Assistant Secretary for Aging, Department of Health and Human Services, and John Feather, CEO of Grantmakers in Aging, from January 10th, 2012. This event was made possible by a partnership between Grantmakers in Aging, the John A. Hartford Foundation, and the SCAN Foundation. Technical and production support is provided by the American Society on Aging.
Welcome to Conversations with GIA. This is the first in a new series of monthly webinars on critical topics of interest to funders in aging. My name is John Feather. I'm the CEO of Grantmakers in Aging, and I am delighted that so many of you have joined us today. We want to thank two of our members for their support in making today's webinar available free of charge to funders in aging. The John A. Hartford Foundation of New York is providing continuing support for the series, and the SCAN Foundation of Long Beach, California is co-sponsoring this month's webinar. We also want to thank the expert team at the American Society on Aging for providing technical and production support for the series. Before we get started, we want to ask you a few questions. So if you could now bring up our poll question. The question is, how familiar are you with programs supported by the Older Americans Act? All right, the results are in. We had most of you said somewhat familiar with 55%, followed by familiar with 21%, very familiar with 14%, and not at all familiar with 10%. So we go to our second question. Our second question for this quick poll is, Meals on Wheels receives most of its funding through the Older Americans Act. Interestingly, because we will return to this topic later in the presentation, 59 of you said that answer was true, and 41% of you said false. And could we have our final poll question? Our final poll question is, federal support for aging programs is growing at the same rate as the population is aging. Well, this one there was unanimity. 100% of you said that was false, and I think we can safely say that that is the correct answer. Thank you for participating in that quick poll. I want to introduce our distinguished guest for today. It is an honor to start this series of conversations with GIA with the highest-ranking federal official on aging, Kathy Greenlee. Secretary Greenlee was appointed by President Obama and confirmed by the U.S. Senate as Assistant Secretary for Aging in the Department of Health and Human Services in 2009. In that role, she directs the Administration on Aging in its mission to, quote, develop a comprehensive, coordinated, and cost-effective system of home and community-based services that helps elderly individuals maintain their health and independence in their homes and communities. Welcome, Secretary Greenlee.
Thank you very much, John. Glad to join you this afternoon.
Thank you so much. We also provide on the next slide some information about Grantmakers in Aging. As many of you know, but some of you may not, we have recently moved our offices to the Washington, D.C. area, and this provides our new contact information. We're here to talk about the Older Americans Act and its reauthorization, as well as the federal budget. We want to start with the Older Americans Act. And Kathy, I want to ask you about the reauthorization, but first want to make sure that our audience is reminded of the basics of the program. Could you tell us how long the program's been in existence?
Thank you, John. Again, I'm very honored to join you for your inaugural webinar. I first met many of you at Grantmakers in Aging when I crashed your reception 2 years ago at your annual meeting in Denver. And I remember that my comments were directed at building partnerships with you, and I think I told everyone I wanted to be best friends forever, and I think we're on a good path. Certainly in the last 2 years I've had the opportunity to meet with many of your members, and I look forward to both the webinar and the other opportunities that we can find together. I had very much hoped to join you this fall at your conference and was just unfortunately not able to because a family member was in the hospital, so I needed to go back home. So I'm glad to be here with you through the webinar so that we can talk about the Older Americans Act. The slide that you have on the screen is one that I use in a number of contexts. I use this information both within Health and Human Services as I work with my peers to talk about our programs, and I use it publicly. And to me, it's an important slide because it shows President Johnson signing the 3 laws that were passed in 1965, Medicare, Medicaid, and the Older Americans Act. I showed this slide recently to a colleague at HHS, and his reaction was pretty interesting. He said, well, there's a law behind you. We all need to continue to talk about the fact that all 3 laws were passed in 1965 because there are many people in the field, and certainly in the field of health, who don't know that there's a foundation in the work that we do that's founded back in the law that was passed in 65. The other reason that this slide is so important is that as your participants indicated when they said that the funding has not increased, the size of these 3 programs are significantly different and certainly have been on different trajectories since 1965, with Medicare and Medicaid being so large and the Older Americans Act effectively staying the same size. It's never sufficiently grown. The other thing that I think is important and why I always start back here is to pause and think about what the purpose was. Medicare provides tremendous acute care medical support for seniors, as we know. Medicaid has become the primary funder of long-term services for many seniors who can't pay for that privately. But the Older Americans Act was designed to be a complementary program, not a means-tested program, but a program that was targeted to people who were at high risk for either hospitalization, nursing home admission. And in that respect, I think of us as prevention dollars, as a way to help buffer the other program costs, but to help support independence and health in the community, which is the ultimate goal of the program. So it's important we talk about 65 as we start.
All right. Tell us a little bit about the programs that it covers and how these programs are administered.
Many of the participants on the call today have some understanding of the Older Americans Act and the structure, but I think it's important that we talk through the various layers of this slide. This is a very unique federal programming structure where we were designed at the Administration on Aging at the federal level to be small and reach into the community. This has always been developed and delivered as a grassroots, community-based organization and services. AOA provides funding directly to state units and to 246 tribal organizations that we have a direct government-to-government relationship with. The states can decide how they would like to organize themselves. This sort of an arrangement has been with us since the early 70s. All but 8 states have divided the states up into regional territories, and those are the area agencies on aging. For 8 states, they've decided the state is small enough they can serve them all directly as one area agency on aging. So there are a number of them that exist, but the common model is for a state to divide itself into various geographic regions. The area agencies on aging are designed to provide planning and coordination for both the services that a senior receives, as well as coordinating with other programs and other service providers in their area. They typically will contract for the next layer of services that you see. They have every service provider from in-home supports to transportation to the meals programs. Our programs have always relied heavily on volunteers, and we'll talk a little bit later about Meals on Wheels. That's certainly one of the areas. The Ombudsman program relies heavily also on volunteers. The services listed there really run from meals to rides to homemaker services. Depending on my audience and sort of what my topic is, I describe these collectively as the services that support health and independence. And that has always been the particular goal and the structure that we have. And this is the structure that we have today. It's been in place for about 4 decades now.
Tell us a little bit more about who this serves.
Well, it's not on the slide, but I thought I would stop and talk about age, since we're at the Administration on Aging talking about older adults. The age in which someone qualifies for most of these programs, Native American programs, can be a little different, is 60. And it's always fun to point this out to my friends and colleagues who are 60 or older. And I point out that just because you're 60 doesn't mean you have to show up to take advantage of these programs. But certainly at the age of 60, if someone has multiple chronic conditions, needs these services, we want them to be available. By and large, the age when someone becomes more frail and needs these services is closer to the late 70s or 80s. But it's important that we know that for our purposes, the older Americans and older adults starts at the age of 60. I said in the first slide when I talked about Medicare and Medicaid that this is not an entitlement program, but it's always designed to be targeted. And we support that targeting by working directly with states, having states work with area agencies as they come up with their plans for service delivery. And we can tell in the numbers that we get back that we're successful in that targeting. Over 90% of our clients, our consumers, have multiple chronic conditions compared to 73% of the general population. Almost 70% of them take 5 or more medications a day. And all of us, because we all here on the call work in the field of aging, understand the complications of multiple medications, and the fact that we're targeting people who have multiple medications is important. And we also achieve the objective of being able to serve people who are at risk for nursing home admission. That of the people receiving home-delivered meals, 35% have at least 3 impairments of activities of daily living, and 69% have 3 IADLs, which is the instrumental activities of daily living. So these are people who need supports in order to remain independent and healthy in the community, and I think we achieve that objective very well.
As one of those people who turned 60 this year, I'm happy to hear that should my needs change, I could have the Administration on Aging programs to help.
Well, I can give you, since we're on, a personal anecdote, because I think most people understand I came from the state of Kansas and worked with Secretary Sebelius when she was the governor. She turned 60 as the governor and came to our annual Governor's Conference on Aging, and I pointed that out to her in front of the audience that she was now eligible, and she took it pretty well. So she's always been very supportive.
That's good to hear. The Older Americans Act has been a very impressive program for many years. Could you highlight just a few of the items that you think are particularly important?
When I have been out in the field, I did a field hearing with Senator Cole about the reauthorization of the law. And one of the people testifying pointed out that in many ways, the Older Americans Act was the original act providing home and community-based services. It is always designed to provide services to individuals in local communities. The data on the slides really tell the variety, the meals that we deliver, the trips that we assist with in terms of being able to get to the doctor's office, the homemaker services, personal care services, the respite care, our family caregiver program is very, very important. And the way I see the Older Americans Act funding is that they're like the support beam of the network. They're not designed to be the full house. They're designed to be the center support. And we can tell that for every dollar we invest in the Older Americans Act funding, there are another $3 generated either at the state or the local level to this network. I think the benefit of the design of the program for both the people providing services, but certainly for people receiving them, is they've always designed to be flexible. And in this regard, they are very different from Medicare and Medicaid. Once you qualify, we will do an assessment and come to your home and figure out what you need now. And if things change and you need more later, you get more later. And the flexibility allows us to tailor our programs and provide just the right amount of support at a cost-effective way. I think the con, if I were to describe in short way sort of the struggle that we have as a network, is that by designing a program that's delivered in each and every community community calls it a different thing. And so we're not as visible often to policymakers and funders and seniors and all kinds of consumers as we would like to be. We are called lots of different things, area agencies on aging. As people struggle with how to attract baby boomers to programs, they sometimes take senior off and call them community providers. I mean, there are different kinds of service delivery names in a community. But it's important that people see the connection and that your members see the connection, that we are a national network of providers providing these services, and we're related to each other, and there is a structure underneath it all, even though the names from state to state, community to community may be slightly different. So they're very, very important and stable network at this point.
Great. Before we move on, I want to remind you that we will be having questions and answers towards the end of the hour, and you can go ahead and begin writing those questions to us, and we will be assembling them to ask Secretary Greenlee at the end of the hour. Let's continue on that topic, if we could, for a second on the next slide. One of the interesting aspects, as you mentioned, about the Older Americans Act is that the programs are often administered by nonprofit local agencies, either at the state or local level. For example, you talk about the very impressive results on home-delivered meals in the almost $250 million a year. But in the local community, many people would know this as Meals on Wheels. But then again, Meals on Wheels is not a federal agency. So how does that partnership work?
It's reflected in the what I call the pyramid slide, the structural slide that I gave you a few slides back. We provide funding to the states. The funding that comes from the Administration on Aging to the states by way of the Older Americans Act is distributed based on a state funding formula. We look at the older population in the state, and that's how it's divided up per capita. The states then organize themselves in planning and service areas, the area agencies on aging, and they contract for services. Most of the area agencies will contract with a meal provider to do both congregate meals and home-delivered meals. There are different kinds of nutrition providers. Meals on Wheels is the most recognizable. That's a fabulous name. It's self-descriptive, and everyone loves it. And Meals on Wheels is a wonderful partner and provider with us, both at the local level and at the national level. There are other meal providers, so one can't assume that all Meals on Wheels are the only thing in town. There are other parts of the network that we support. But they're not a federal agency, so they're ours. They're the on-the-ground reach that reflects what we're investing at the federal level, but they're not ours. They are delivering our programs, but their entity is their own. And local Meals on Wheels providers or nutrition providers are typically their own nonprofit entity. Area agencies on aging are aligned a little bit differently. In many places, the Area Agency on Aging is actually a county-based organization, and you'll often see a county provide a wide range of services to their residents, and the senior programs may be part of it. In other places, the Area Agency on Aging may be a nonprofit organization. So the structures change from state to state. The constancy is the revenue flow that goes down to the local network. The design of the program was always that an area agency would contract for another provider. There are parts of the country where there simply aren't enough resources to go around, and the area agency provides direct services themselves. Having come from Kansas, I can tell you that's how we deliver the meals in Hays and out in western Kansas, that the area agency provides direct services. We can support that. They have to work with us to get a waiver. So there's different kinds of distribution channels to support people both in the rural area and in the other parts of the state. But it's really critical that these providers be supported and that people understand that Meals on Wheels is not just a free service out there that magically shows up and provides meals. There has to be support for the program, and there has to be dedicated funding. From everywhere I go, both working with members of Congress, working with the Kansas legislature, working with other providers, this is really our flagship program. The meals programs have always been the primary thing we fund. It's 40% of our program dollars, and this is a strength of ours. It can also be a weakness in that we often have to then show up and tell people we are more than meals. People sometimes need a meal in order to stay independent, but they may need a bath, and they may need an in-home aid, and they may need a ride to the doctor. So we have to provide a full range of services, and those are really reflected in the earlier slide that I showed you.
Right. I know that you've been preparing for the reauthorization of the Older Americans Act, and you went throughout the United States and held over 60 listening sessions in local communities about what works and what needs to change in the Older Americans Act. What did they tell you?
Well, the first year, I'm now in my third year, I'm glad to say, as Assistant Secretary. I did travel a lot the first year. I did not do all 60 of these listening sessions myself. I'm not sure I would have made it to the year 2. We did put in place a structure that was unique for AOA. I did a number of listening sessions myself. I did one at the ASA conference that year. I did one in San Francisco, here in Alexandria, where we are today, and down in Dallas. And then we encouraged our stakeholders, our partners in the states and local communities, to hold their own events. And that's where we come up with a number of 60, is that we really push to the network our need to get information from them and have them convene locally and give us their information. They did that. We received reports from more than 60 listening sessions. And we also set up a fairly sophisticated online tool where we could gather information really going through the law program by program to get detailed information. And this was historic. We got input from thousands of consumers about the Older Americans Act. And it was consistent in this one regard. It's needed, it's valued, and it's working. And so that needs to be the theme as we continue to talk about reauthorization, that the law is working, it's not broken. And it's something that we need to continue to support everywhere across the country, in rural areas, frontier areas. And it is a structure that holds everything else together. We see it as a glue, and it's meeting the needs that it was designed to meet. And so it was a wonderful opportunity, and I must tell you just personally, having the opportunity to serve as Assistant Secretary, to have that chance my first year was really special, to be able to both go out and meet members of the network and also hear the affirmation for the programs that we're running was really special for both me and for my staff at the Administration on Aging, both here in Washington and out in the States, that what we're doing is good work, and we need to continue to support it.
Great. Well, now we get to the heart of the matter on the next slide, and that is the Older Americans Act will be coming up for renewal initially in 2011. My understanding is that the bill has yet to be introduced. We all love our American democratic system, but also know that sometimes it's a difficult system to manage. What's your sense of the status of the legislation? And particularly in a period of political gridlock, is it possible to get this done?
The way the Older Americans Act is designed is it's up for federal reauthorization every 5 years and was up for reauthorization in 2011. So to give you the technical correct answer, at this point it is operating without authorization, that the authorization expired at the end of the fiscal year in 2011. We have been working, obviously, as we've described in our outreach, both with our partners within the federal government as well as with Congress, to figure out how we can move forward on reauthorization. We have good support from Senator Sanders, who's the chair of the subcommittee in the Senate, who has jurisdiction over the reauthorization. And I met with Senator Sanders and his staff almost a year ago at this point as they started looking to shape reauthorization. He's a strong, strong advocate for these programs. And I had to really convince him I was too. I mean, he is really a strong advocate and is particularly concerned about senior hunger and poverty. So I think he will be a good champion. And he's determined to get support and move the bill. He will be introducing his package, his reauthorization package soon, I think this week, and really went through a process at the staff level over the course of the summer of getting input on a variety of topics. I missed the earthquake in Washington. I was up doing a field hearing with Senator Blumenthal, but on that day there was a hearing here to talk about elder abuse and to get information from the network. And so the staff who support Senator Sanders have done a good job of being able to reach out and get some good input as they come up with their own opinions and their own ideas for the law. We're likely to see a base law being suggested, and then there will be other amendments as we move forward. I had the chance just a few weeks ago to go to an event that celebrated the 50th anniversary of the Senate Aging Committee. And it's important when we're talking about the reauthorization to stop and reflect on something that we all know, which is that this is a nonpartisan issue, and we need a bipartisan approach to being able to move forward. The Older Americans Act has a history of bipartisan support, and we certainly, I said this to Senator Sanders in my meeting a year ago, I'm willing to work with both Democrats and Republicans on the House and Senate side to be able to move forward the program. What I think is likely to happen is that we'll continue to see good support and movement in the Senate. I doubt that the House, just personally, will move this soon. And I think it's important that we keep talking to the House. I met with the House Seniors Caucus, it's a Democratic caucus, this summer to also talk to them. There is support in the House, but we'll need enough support that we can actually move the legislation. In the meantime, we can continue to run, even though the law has not been authorized, so long as we continue to get appropriations. So that's kind of the current status of where we are.
Okay. Turning then to that specific issue of not the reauthorization of the Older Americans Act, but the funding for the law. We're all already well underway in fiscal year 2012 for the federal budget. And how did aging programs fare this year in the federal budget?
Well, the aging programs are flat this year, and I might connect this to the conversation about the reauthorization. I did the same thing at each of the listening sessions I had on reauthorization. I stood in front of the audience, and we had hundreds of people there, and said, okay, the reauthorization is about that. Do we have the authority that we need in the law? It's not about appropriations. That's different. I opened and closed each session with a reminder that the law is being reauthorized, and that's separate from a budget. And in the middle of all that, everybody talked to me about budget. Which is why it was important that I both open and close and talk about authority. The law is working. The struggle, and I hear this from every aspect of the network, is funding. How do we continue to support the program and support the funding that the program needs? That has been more of a problem for the network, really, than the authority that's in the law. Both in 2011 and 2012, President Obama, in his budget, recommended significant increases for the Administration on Aging. This was kind of characterized and promoted as a caregiver initiative both years, focusing on providing increases, almost kind of $50 million for each, for both services for the care recipient, additional services for our family caregiver program. We were thrilled to see this kind of support coming from the administration, and unfortunately, those budgets were not realized. So we have a unique time where we've got tremendous support, but are hitting the budget realities that all programs, all federal programs are facing, state programs are facing. Our budgets have been flatlined. I can't say that that's good news. They weren't cut, that is. And so we all have to stay at the work and keep talking about the value of the programs so they not get lost in the larger conversation. What has been lost, and this is a reflection just of the economic time, is additional support or base support for the Administration on Aging for innovation and innovation funding. The very first meeting I went to, the American Society on Aging, and John met with members of the board, you're probably there, I heard from so many people, and I continue to hear from so many people who got into the field of aging because they received funding from Title IV of the law, where we have discretionary program dollars. And those dollars have historically done two things. They've advanced the delivery of programs by being able to try innovative practices, and they've helped the career paths and professions and trainings of people to encourage them to get in the field. Title IV programming was cut significantly in the past, in the 80s and early 90s, and we continue to have a real challenge in being able to fund innovative programs. Much of the AOA dollars then are formula grant dollars, and they're critical to all these programs we're discussing, but they're not flexible dollars. And as we look at an aging nation, I think it's important that we continue to be able to innovate. And my vision of innovation is that we innovate to improve our own programs, or we innovate to improve the programs that other people are running, especially in the federal government.
Right. I, too, was one of those people that had Title IV funding at very early on, and appreciated it and wish we had it back. The Older Americans Act and the whole aging network is often talked about as the glue that holds the fragile system of services for the elderly together. Are you concerned that, given the federal budget and so forth, that the glue is losing its grip?
I'm concerned that we're asking the same amount of glue to stretch further, yes, and that would be the ultimate result. With increasing numbers of seniors and a flat budget, then we can all do the math. Our ability to penetrate the percentage of people that we can serve is significantly diminished, and yet there's still the same basic need to help frail seniors remain healthy and independent for a lifetime. So we can't do as much if we have more people to serve with the same base of money. We talked earlier about the way the federal programs have always been leveraged at the local level. So I think logically, if we look at flat federal funding, all of us and our partners would see how to supplement the federal dollars with foundation dollars, state dollars, nonprofits, community dollars. But this struggle that we're having as a nation with our budgets is up and down the line. And so we're seeing cuts at the state level. Many states have provided their own support for Older Americans Act programs, nutrition and other programs. We're seeing cuts in county budgets. A lot of services are delivered at the county level. And then nonprofits, and you all would know this. I mean, you have less money to spend and invest than previously, if nothing else because of return on investment. So there's been a real shrinkage in support at a time when there's a real need. Aging programs can be counter-cyclical in the way that Medicaid and other programs can. So we all have to hang together and realize that we have to protect the infrastructure and protect the core and keep going about the work.
Before we come towards our end, 10,000 baby boomers like me are turning 65 every single day, and that will continue for some time. Any final words about what you see in your crystal ball for aging programs in the future?
Well, I mentioned that I had a chance to speak at the Senate Aging Committee Forum, and it was a wonderful event, and the reception following, several of your members were there. It's nice to go attend something in Washington that's so well supported on a bipartisan basis and has a long history. One of the things that I did just very shortly is go back and look at all the changes that have come about since the Senate Aging Committee was put in place 50 years ago, including Medicare and Medicaid and the community waivers that Medicaid is providing, the Americans with Disabilities Act, the Olmstead decision, the Nursing Home Reform Act. And we've done a lot for seniors and people with disabilities in the last 50 years. I don't spend a lot of time on statistics, but I do want to stop as we talk about the future and absorb it. I mean, we are in this 5-year span that from 2010 to 2015, the population age 60 and older will increase by 15%, from 57 million to 65 million. And then they grow. I mean, from 2015 to 2030, it's projected there will be over 72 million persons age 65 and over, 8 million over the age of 85. Having the seniors turn 65 this year doesn't panic me. Most people, fortunately, do not need these kinds of in-home supports at 65. In 15 years, they will. And so this needs to be a focus point. This was what many people hoped the reauthorization could do for us as a nation, not just talk about these programs that are so needed, but focus on a policy that we need to be looking at the services that seniors now will need in 15 years as the baby boomers start to become frail. That's really the point, and when services will be a challenge. When I spoke at the Aging Committee, they asked me this similar question about the future. So I'd like to frame my answer about the future kind of in 3 different categories. I think in the future that what we have to continue to do is talk about prevention across the lifespan. I pointed this out on my first slide when I said, in my opinion, the Older Americans Act was always designed to be prevention dollars. And in my just professional experience, 2 decades now in government service, prevention dollars are always hard to come by. Whether you're working on children's programs or mental health programs, prevention dollars are always as hard because it's unfortunately, people make budget decisions based on current crisis and can't invest in the long term, even though they want to. When we're talking about prevention, I would ask that all of us talk about a lifespan approach, because my fear in talking about prevention is that we get trapped in this discussion about what primary prevention means. And I have seen, and this worries me, conversations get high-centered on investing in children's programs, and we should invest in children's programs. But I think it's important that we talk about the lifespan. What is the right investment to make for an individual at every stage of their life, and continue to have an agenda for aging that focuses on primary prevention. I believe medication management, falls prevention, are primary prevention programs that we can use and support and demonstrate and test and research to help an aging population stay healthy, and it's worth the investment. There is ageism in this world, and everybody on the phone is probably nodding. We have to talk about seniors and prevention, or it won't be discussed. The second thing in terms of the future is I believe the opportunity to go back and do something they didn't do in 65, which is figure out what's the relationship between acute care services, long-term services, and community services. I think the Affordable Care Act has given us a new opportunity to revisit that question and talk about our more holistic approach. I see this coming in conversations about accountable care organizations, even the Office of the Duals looking at Medicare and Medicaid, certainly medical homes, you'll see this in different ways, care transitions. How can we see a person holistically and look at the systems that they move in and out of as they need acute and long-term services and help them get the community services that they need and connect them together? That this kind of a holistic approach and this integration is critical to moving forward. And then the third opportunity that I'd just like to call out is that as we have increasing numbers of seniors, more of us in the baby boom generation, I'm in there too, as we're all aging, we don't all look alike, and we haven't all come from the same communities. We have, unlike any time in history, an increasingly diverse group of older adults in this country, and need to make sure that our programs are delivered in languages other than English, need to make sure that our volunteer staff and our provider staff, the people we hired, reflect the diversity of this country, and that we stop and make sure that we do the special attention that we need to reach all populations and not make assumptions that all seniors are alike. I actually find this to be one of the most interesting and exciting aspects of the field of aging. I think when you start talking about diversity in aging, that you can see how all cultures have such common respect for family, their own faith traditions. All people want to stay in the community, that here both diversity and cultural sensitivity and aging all convene or converge in kind of the same dynamic, which is how can we help you and your family stay together, stay in your community, and stay involved, and not be a part of another community, your community. And I think it's real important that we support that moving forward.
Those are all very important observations, and we thank you for that. Our next slide would be on what you think we should be doing. So we've talked about what the federal government does and can be doing and should be doing, but what should philanthropy be doing? And this is obviously an audience of people who work in the funding arena. So what are some of your suggestions for things that funders can be doing?
Well, I thought it was important that the very first thing I say in response to this is serve as ambassadors. That when I look at your members at GIA or any of the individual foundations, I understand that you're funders. I'm a funder as well. I think the partnership overrides that, and that what we all need to do is be ambassadors on the policy issues affecting the field. When I was in the state of Kansas, we started to have to cut programs, and I came up with a phrase that I think is very applicable here. We are more than the programs we run. You are more than the funds that you have. You are more than the things that you provide services to in the community. You can help us talk about aging issues in a number of venues and help overcome a blindness that sometimes people have to the fact that there are seniors with needs and that we can do things to help this population in a way that's effective. One of the ways that I see that you could be ambassadors, all of you, is to help us message with regard to the field of health. And, this becomes kind of tricky. And I met with some Grantmakers in Health recently. Many of your members, some of them on the phone, were in the meeting. There are people who look at the field of aging and equate it with long-term care and then shortcut to think that we're all just doing nursing home care, don't understand it. So it takes all of us to say, no, long-term care is long-term supports and services. And when you can kind of soften them up, this is long-term supports and services, it's easy to see that really what long-term supports and services are long-term supports for people with chronic conditions. And there are many people working in that space that don't consider themselves working in the field of aging. If you're working on congestive heart failure or diabetes, multiple sclerosis, Alzheimer's, you're working on long-term supports and services. You're working with seniors. So part of it is to help people see that they're already doing the work. It's not so much having new people do it, but having the people who are help support it see it and say, you need to be at our table. And so if you make that transition from long-term care to long-term supports and services, this is chronic disease management, then it's easier to pull prevention to the table and say, we need to talk about prevention as well, that there are investments. It's still worth it to invest in older people. And you have to say that sometimes for people to believe it. So that's the main thing. I mean, there's money, and I think the things we can do to help support direct service providers in the community, to help support planning and coordination. I mean, there are many other things that are needed. Transportation, I think, is one of the thorniest issues facing us. I'm not easily unnerved. Transportation is so large as a policy issue, it's been unnerving to me. As we continue to drive toward the nation, sort of a pun, to provide services in the community, how will people get around? I mean, that is going to be a significant issue. So helping us with and helping communities with planning coordination. And I'm also then very interested in quality. We have been working at the Administration on Aging for a decade to talk about evidence-based programming. And I say this to my friends on the health side quite often. We cannot assume that data and science belongs only in acute health care. Data and the science belongs in social services as well. And how do we demonstrate in research not just outputs but outcomes? And those outcomes have become more sophisticated. We can show you how many meals we provide. We can show you that by doing that we have fed people. That is a worthy goal. We should not lose that goal. But we must also show more. What other kinds of impacts did that have on someone's tenure in the community? Did it save them other dollars from the acute care side? Helping us demonstrate and innovate and understand that we're losing our ability to fund innovation at the federal level, but innovation is needed. And those innovative programs either make us better or bring to us new programs that we should implement to help people stay healthy for as long as possible. I spend more and more time talking about quality, and I said at the conference last year, at the ASA conference, that I believe data is our currency moving forward, and I believe it. I think we need to continue to talk about evidence and prove what we're doing is worth the investment.
A big set of goals for all of us to work on together. At this point, as we move to our last slide, which provides some resources for you from the Administration on Aging and also about the Older Americans Act prepared by the National Council on Aging, we want to turn to your questions, and you may provide those at any time, but I also want to start with some of them that have been submitted already. And the first one is about the impact of the, quote, Supercommittee, unquote. And it has to do with the Budget Control Act, which mandated cuts into the federal budget if there was not a agreement about how those cuts should be happening. Is that something that's going to have a direct impact on the Administration on Aging programs, and in what sense do you see that having an impact?
You know, it's premature for me to be able to give any specifics. We have just, as you know, received our 2012 budget, and the President will be moving forward with the 2013 budget. So I don't have specifics on what that might mean. There is, I guess, a piece to watch that I would just point out to people as they watch those large federal policy conversations. Often you will hear either the President or Congress talk about mandatory programs and discretionary programs as they look at budget cuts or revenues. The Older Americans Act programs are discretionary programs, and so it's important as people watch what's going on to be able to translate that and understand that when discretionary dollars are being considered, that's where we would fall. But I don't have any specifics that I could provide at this point.
Okay. Can you suggest any particularly effective programs to promote aging in place and delayed entry into nursing homes, or a place to identify evidence-based practices in this area?
There are a number that we have been working on. I would direct people back to our website. I've got some staff here. We need to make sure that I got the right information so we can direct you. We have been funding and partnering with other entities such as the National Council on Aging a number of evidence-based practices: diabetes self-management, chronic disease self-management, falls prevention programs, exercise programs. There's a diet program, a DASH diet program, medication management. I mean, there's a whole list of them at this point that we've invested in. And we have been working to be able to validate them and move them out into our network, working with the National Institute on Aging and others. I don't have a list right here, so what I need to do, John, is either follow up with you directly and point you to where they could look for a list. But we certainly are gathering that and trying to assemble that in one place so people can see. It's not big enough.
Right.
It's important. It has to grow, and really critical that we keep investing.
Would there be things on your website at this point, or should we provide this information later?
If people go to AOA.gov right now, there's information. So I think we should try both. Let me get the information back to you, but people should be directed to our website as well.
The next question is about home-delivered meals or Meals on Wheels. as you said, if the need is shown, then enrollment in the program can be automatic to some degree. But the question is about the long waiting times that exist in some communities to access these programs, even after the person's certified as being eligible, due to the lack of funding. What can we do about that? Can the philanthropic community be involved in that aspect? What are things that your office is trying to do?
The experience that someone has will be different community to community with regard to the ability of the meal provider to provide assistance then or be able to do it later. I mean, use a waiting list. The waiting lists are always kind of tricky. There may be some providers who don't have enough resources who also don't keep a waiting list. I think it's important to stay in touch directly with the meal provider about the need. And to the degree that people want to do any advocacy, that they talk about the unmet need. I have found this to be the hardest thing that I ask seniors to do when I speak to them directly, because people are very proud by nature, and seniors are certainly no exception, is to talk about what they're struggling with. I think it's important that people hear if there's a waiting list, and that that's not a single responsibility at any level of the government or United Way or you or anyone, but people have to step forward and say, there's a waiting list, that's not acceptable. What can we do to help support it? How do we make other priorities? And talk about it publicly. This is also true when I talk about family caregivers. Family caregivers are kind of, I have a whole seminar on family caregivers. But people who are have taken this labor of love are often very, very stressed, and family caregiver programs can be very challenging, and I mean the issue is very challenging. And it's important for people to say, I'm really struggling with this, I need more help. And I would just encourage people, if they're struggling, to talk about it so that policymakers know, and then we can all be involved in the debate about the priorities, and I think that's where it comes down.
Okay. This is a question more specific to the foundation world itself, so that's a great one for us. Community foundations often house donor-advised funds. And those are, when the donor sets these up, the donor says that they want the funds used for a specific purpose, but the community foundation then administers those funds. And they're usually designated for direct services, while program funds can be directed to advocacy, system change, and coordination. The question is then, are there ways to leverage this duality of roles in the community foundations? How can If someone's left money for Meals on Wheels, for example, but we need to do a better job in coordinating services across the whole aging spectrum, might be an example. Are there ways in which foundations can do that in a more effective way?
I would encourage foundations to meet and work directly outside of the funding or grant cycle, but to meet directly with the local organizations that are providing services so that they can understand their funding. Often, for what we do and other local providers, there's a tremendous need for match. We can be fairly creative in how we interpret match. We can't make it go away. I have some discretion based on kind of hardship to sometimes change the number, but we often need local match. And local match is required or state match is required on the formula grants. But certainly, if we had a funding opportunity to do something new in the field of Alzheimer's and the state didn't have resources or the local partner didn't have resources, these dollars could help provide match. And it's in that way that our federal dollars can be leveraged. That's how they're designed to work. So I would do whatever kind of planning cycle Community Foundation has. I would invite the other service providers to come in and talk about their needs and get into the financing, so that you can understand how your dollars might be leveraged. But I wouldn't do that with the funding proposal in front of me. I would do that separate, so that you could really have a more candid conversation outside of a specific budget request.
Really an excellent suggestion. Next question is about whether there are, either from the Centers for Medicare and Medicaid Services that run Medicaid and Medicare, or from the new healthcare reform law, programs to provide additional direct resources to community-based prevention programs in aging.
The CMS programs that you're referencing are being administered over through the Centers for Medicare and Medicaid Innovation, CMMI. The primary objective through CMMI is to be able to implement delivery systems reforms that can improve health or reduce costs. And it's in that way that we come to the table as community providers saying we can do both. We can help stabilize or support someone's health and independence and lower costs. We have been successful in being able to provide targeted education to our network of providers with regard to care transitions and what we can do to have an area agency on aging or an aging and disability resource center, which is part of our network that provides kind of long-term services. We're encouraging those relationships directly with hospitals so that we can focus on care transitions. That's the first place to start. Other kinds of ideas that we can pursue can have a prevention sort of objective, but they have to be tied back in being able to demonstrate some cost savings quickly on the acute care side as we look to try to get a handle on increasing healthcare costs. So I see this as a bridge opportunity, not the whole solution. I believe that the primary focus of health reform was largely on both dealing with the issue of the uninsured, but also systems reform on the healthcare side, and that we can be part of their answer. This will not be all we need in order to provide community services, but we certainly can find new revenue sources and new opportunities for our network to really promote what they know, which is how to help someone as they transition between settings, and in doing so, how to get community supports in place.
Our final question before we ask you to wrap up and give us your final words of wisdom. How can foundations most effectively directly advocate or develop the capacity of others to advocate on aging issues? How effective would foundations' involvement in advocacy be?
One of the reasons that I was attracted to this work in the first place, I'm a lawyer by training, was that I liked the fact that in the government programs, the people working over there in aging were required by law to be advocates. It's in the law. If you read the Older Americans Act, it clearly says that is our role in the network, that is a role of the Assistant Secretary, and that trickles down to every aspect of our network, that we really want the states to advocate, we want the local community to advocate. Unfortunately, there's never been a dedicated funding stream to pay for it. So what we're finding is that often service providers make hard decisions, and if they have someone on a waiting list for meals, they'll do that rather than hiring someone who can do the community coordination and the advocacy. It's infrastructure investment that's important. And when I go back to what I said earlier, my phrase I came up with my Kansas staff, that you're more than the programs you run, it's hard to find an infrastructure that will fund someone to talk in that way and say we need to look at a systemic approach to pulling people together. There is a role for philanthropy there, but it's at the community level. So what I would encourage people to work with community foundations and others to figure out how they could best support in a community someone who could specifically focus on the needs of seniors. And I would challenge my own network to think more broadly, that they are very appreciative of, dependent on, supportive of the Older Americans Act programs. But we need for people to advocate for seniors who are on Medicaid, to advocate for seniors who are low-income housing, to advocate for seniors who need transportation. And we need our network to be engaged on all fronts and not just providing these very, very valuable but limited services on a whole range of services that help someone stay independent. So I would work at the community level. That's the best place to start.
Great. Before we turn to closing our session for today, could we have your final words of advice to all of us?
I just want to thank you for your interest and your support. There are not enough of us in this field who call out and pay attention to working with seniors. I think it's fabulous work. It's energizing work. My very first day when I started at AOA and met with my staff for the first time, I told them that if anybody forgets why they're doing this work, they should leave and go to a nursing home. That ultimately people want to make that decision last. And if you go to the nursing home, it'll remind you why we're doing this work. We need better quality care in nursing homes. We need community services for as long as we can provide them. And seniors deserve it. They're worth it. And these investments are worth the time. This is passion-driven work, but it also has to be based in fundamentals and good quality. and we need everybody at the table. We need to be talking, as I said, as ambassadors for seniors, and talk to other people about the growing needs we have in this country. I also am just, if I could have you help me just get rid of this term silver tsunami. That would be my final, and I think I talked about this when I met you 2 years ago, that the opportunities we have with this aging population is significant. We have healthier people, people who live longer, people who have assets and social capital and energy, and we need to harness that to help us provide the care for the other seniors who don't. So I'm a big fan of GIA and the foundations that you work with.
And we're a big fan of you, too, Secretary Greenlee. We appreciate your tremendous passion as well as your knowledge of these issues and your advocacy in every sense at the federal and state and regional and local levels. And we certainly appreciate having you here in this first of the conversations with GIA. I also want to thank the John A. Hartford Foundation and the SCAN Foundation for their support of today's program, as well as the American Society on Aging for their technical expertise. Our next webinar will take us from the national level to the regional level and talk about how foundations in the Rocky Mountain area are collaborating with state and local aging programs, including AOA's state program in Colorado, to better meet the needs of aging in place in locations in rural areas which may be miles and miles from services provided. There will be more information coming to you shortly about this program in later February. Remember, we also need your suggestions for future topics and speakers for Conversations in Aging, so please send us your ideas. And finally, I want to thank all of you for participating in today's webinar. Thank you, and great day.